I'm welcoming today Dr. Khaled Halaf, Dr. KK for short. Dr. KK is an interventional cardiologist, vein specialist, and structural cardiologist based out of Houston.
Yes, sir.
Thanks for joining me today.
Thanks for having me. Pleasure.
So here we are at ACC in New Orleans, and we're talking about PE. Mm-hmm. And I think that alone is remarkable. But you, KK, are someone who has really embraced this VTE space. Yeah. In particularly a place where there is a lot of cardiologists doing a lot of different things.
Yeah.
So I'd love to hear a little bit about, your interest and how you sort of started building a program.
Yeah. Thanks, Doc. Thank you. What's interesting for me, my story is a little different. It's a little unique. When I was in fellowship, we actually didn't do I don't think we did any DVTs, right? And we did a handful of Ps. At that time, Inari wasn't available, and so we were doing a catheter-directed thrombolysis. And so that's the first time where, as a fellow, there was something new, right? Something different from the traditional medical management, right? Which essentially is just, I call doing nothing, right? Doing what you're supposed to do, right? Not doing something different. And so it was new, it was exciting. My program started a PERT team that eventually didn't take off, by the way. It was more just something to do on paper, but the logistics didn't really allow it to happen. And so now I start my practice, right? And I'm in a hospital a little north of the medical center, and there's a tremendous amount of thromboembolism, DVT, PE. We're close proximity to the airport, and so we had patients coming in. I once had a pilot come in. I mean, it's just a tremendous amount, and they didn't have much there. And so I said, guys, there's this catheter-directed thrombolysis thing that I did in fellowship, a little bit of it. We should bring it in here. Why not? Let's start helping these patients. It works. Yep. Let's be at the forefront of technology. And then that's kind of how I got involved initially with the catheter-directed thrombolysis. And then fast forward, then Inari comes to showcase their product. And I remember they showed me the product, and I was like, this seems like a lot of work. Initially, I was like, I said, no, just throwing in a catheter is easier. When in reality, now looking back, it's the complete opposite. Now with thrombectomy, I don't have to do ICU. I don't have to watch them closely overnight, really. I don't have to check their labs and fibrinogen so often. I don't have to bring them back the next day. So, and I'm always willing to try new technology, right? I think the people that are unwilling to try new technology they're because how are we going to grow as a field if we don't try things? Sure. So that's kind of how I got involved initially. And then I remember my first clot treatment case. I was so excited. When I pulled out all this clot. And I was like, oh my goodness, what is this? You see it on the table, and it's like I started playing with it like a kid, Yes. I was excited. Yeah. And, as an interventionalist, our job really becomes mundane and routine. Like, we don't get necessarily too excited all the time. So it sparked something within me. And then I essentially just went on a campaign. Just a campaign that I felt obligated to do to spread this word and tell everybody, hey, look what we can do now. And the one thing I did that I think helped is I always sent the before and after pictures and pictures of the clot to all the doctors involved in the case. Yep. Because seeing is really believing, right? If you tell a doctor, hey, patient did well, okay, great. But show them what you did. And then they started to buy in. And then slowly the hospital just kind of grew. Now it's almost become standard of care in our hospital.
It's remarkable. Yeah. You and I talk about this a lot, this sort of phenomenon of, for the first time ever, unless you were a surgeon doing endovenectomy, for the first time ever, seeing this pathologic thing that was in your body that is now out of your body. Yeah. There's an intuitive thing, I think, as an interventional clinician, that, okay, this must be good for the patient. I think what we're starting to see now, KK, is longer term data catching up with what I think is inherently intuitive to those that do the procedure. Data like the cloud study that showed across a range of chronicity that we have freedom from PTS, we have good long-term outcomes and safety in these patients. Tell me a bit about your evolution now. You'd mentioned a lot of this field was built upon catheter-directed lytic therapy initially.
Yeah.
Are you still using lytics now, and what was your evolution once you started doing mechanical?
Yeah, no, that's a great question. So there is still a role for catheter-directed thrombolysis, in my opinion, in the distal PEs, because when you start getting into the segmental branches, it creates a little more complexity for the case, right? Let the TPA do the work is what I tell sometimes the people. Mm-hmm. But in reality, I can't even remember the last time I grabbed a thrombolytics catheter. I really can't remember. A lot of more, if you're taking the patient to the lab, that means that the patients are sicker generally and the clots are more proximal, saddle, or close to it. And for DVTs now, I've completely abandoned using lytics. I'm completely clot retriever. And what's interesting about the DVT space is that it's evolving, and as we do more and more, we get much better at it. I'm a big believer in really trying to clear out as much as the popliteal vein as possible too, as opposed to just accessing within popliteal thrombus. So PT venous access, trying to clear out now with your Enthrall device that really helps kind of with that as well. Basically taking the clot retriever and shrinking it, if you will, to a device that will work below the knee. And we've had just excellent results.
Well, let me key in on that for a second, because you've done a number of cases. You've created an environment where you're, and we've talked about this as well, known as the DVT person in your community that can do something for patients. It's created a robust referral network for you. What are you seeing in terms of safety? I think for folks that aren't as well versed here, there's apprehension with a coring element, with multiple passes. Coming down against the grain, if you will, through the pop. So tell me about your safety experience.
I have never had a complication with DVT or PE. I can tell you that. Now, a lot of people will say, oh, well, maybe he's just being a little out there. I'm telling you the truth. If I had one, I would tell you. I had a complication with catheter-directed thrombolysis, but guess what it was? Nurse did a poke while the patient was getting infused overnight.
Oh my, okay.
Which she wasn't supposed to.
It's going to be a mess.
Right. So, so in reality, that's not even a complication. That's really my direct fault. But the safety of this is remarkable. And for, experienced plumbers who do a lot of vascular work, we're always in vessels, and just being careful and knowing not to push things if you feel resistance, not going crazy. The safety of these devices, flow retriever and clot retriever, is phenomenal. Phenomenal. I really haven't had an issue at all to speak of.
Let me ask you, as we get more and more people interested in this disease state, and I'm seeing this across disciplines, it's not just interventional cardiology, it's vascular surgery with endovascular skills, it's interventional radiology. What advice do you give people that are getting started in terms of doing these procedures and seeing these patients?
To do it.
Yeah.
To do it. All the young fellows that are coming out in training, I tell them, wherever you go, do it. It's right now we're at a state where right now the gold standard, if you will, for the treatment of DVT and PE is not correct. And I know it, and you know it. And a lot of people in our community know that. And it's inevitable that intervention will become the gold standard. There's no doubt in my mind. I've been saying this for years, but here we are years later still talking about it.
Yes.
Right?
Yeah.
And so you take a look at the algorithm for the treatment of stroke and MI and how much it's changed. To me, it's going to happen. It's just spreading the word. Like I said, going on this campaign and telling people, and it worked. I mean, locally it worked within the two major hospitals that I work at. Now it's like if DVT or PE comes to the ER, they immediately know who to call. But that took effort. That didn't happen. That didn't happen because they got an email from their ACC-AHA and looked at it, right? This happened because of direct communication, physician to physician, peer to peer.
Dr. KK, thank you for your time. Thanks for your expertise and what you do for our patients.
Thank you, sir. My pleasure. Good being here.